Welcome to the Funnel Effect. Today we are diving into a comprehensive JCC state-of-the-art review titled Pulmonary Hypertension Associated with Left Heart Disease: Challenges, Emerging Strategies, and Future Directions. This massive review was authored by Mohammed Shahzad Khan, Barry A. Borlaug, Javed Butler, Marty Gomberg-Maitland, Mark Humbert, Carolyn S.P. Lamb, Yogesh N.V. Reddy, Greg W. Stone, Fayez Zanad, and Ryan J. Tedford.
It's an absolute honor to be breaking this down with you today.
Yeah, and the mission for today's deep dive is it's pretty profound for the listener. We're exploring what is undoubtedly the most common, yet completely misunderstood and, quite frankly, under-investigated form of pulmonary hypertension.
Oh, without a doubt. It's historically just fallen through the cracks.
Right. We're going to unpack exactly how a failure in the left side of the heart creates this devastating domino effect all the way over in the lungs. We'll look at why traditional treatments have, catastrophically failed, sometimes with fatal results. And then we'll get into the incredibly futuristic devices and drugs that are racing to fix it.
Yeah, it's a topic that sits right at this messy intersection of cardiology and pulmonology.
Exactly. I mean, imagine your heart is the plumbing system of a house, right? For decades, when the pipes on the second floor, which are your lungs, kept bursting from high pressure, doctors would rush upstairs and just stare at those specific pipes.
Right, trying to patch them up.
Yeah, desperately trying to reinforce them while completely ignoring the fact that the main drain down in the basement, the left side of your heart, had been clogged the entire time. If you're walking up a flight of stairs and you feel unusually winded, you probably think it's a lung issue.
Which is the logical assumption, of course.
But today, we want to show you how this massive systemic issue actually starts far away from the lungs. So let's just start with the sheer scope of the problem.
Let's do it.
Because when we say pulmonary hypertension, or PH, affecting about 1% of the global population, we're talking about a broad umbrella. But the specific type we're looking at today, group 2, or PH associated with left heart disease, which we'll just call PH-LHD, that accounts for a staggering 65 to 80% of all cases.
It's massive.
Yeah.
And to really grasp that percentage, you have to look at the global rise in heart failure.
Right.
Because group 2 PH is inextricably linked to failing hearts worldwide. Just looking at the prevalence, it affects anywhere from 40 to 72% of patients who have heart failure with reduced ejection fraction, or HFrEF.
That is a huge chunk of patients.
It is, and it's even worse in patients with heart failure with preserved ejection fraction, HFpEF. In that group, it develops in up to 83% of patients.
Wow, up to 83%.
Yeah, and the incidence is only climbing. Between 2002 and 2012 alone, it rose from 51 to 67.4 per 100,000 people.
So why should you, the listener, care about these numbers? Because if you or a loved one is managing any form of left-sided heart failure, there is a massive statistical chance that this secondary deadly lung condition is just quietly developing in the background.
Exactly. And the terrifying part is that the medical community was actually undercounting it for years.
Wait, really? How do you undercount something this prevalent?
Well, our diagnostic definitions were just fundamentally flawed.
Yeah.
We were missing the disease in its early critical stages because our numerical thresholds were set way too high.
Okay, let's unpack this. What were the numbers?
So back in 1978, the World Health Organization guidelines defined pulmonary hypertension as a mean pulmonary artery pressure, or an MPAP, of 25 millimeters of mercury or higher.
Right.
But recently, after looking at modern data, the community officially updated that. They lowered the threshold to anything greater than 20 millimeters of mercury.
Lowering it from 25 to 20, to a layperson, that sounds like a tiny administrative tweak. But if we compare that to lowering the threshold for standard high blood pressure, suddenly you have a whole new massive population flagged as at risk.
That's the perfect analogy, and the data backs it up completely. The review cites a huge meta-analysis of 15 trials, and it showed that even a mildly elevated pressure just sitting in that 21 to 24 range independently leads to a 1.5-fold higher mortality risk.
Just from that slight elevation.
Yeah. By waiting for the pressure to hit 25, we were essentially waiting for the house to be completely on fire before calling the fire department.
The way pressure fluctuates normally, right? Like if I exercise, my pressure goes up. How do you tell the difference between healthy exercise and a deadly disease?
That's where we have to look at pulmonary vascular resistance, or PVR. It's not just about pressure. It's about the physical friction, the actual roadblock the heart faces.
Measure in Wood units, right?
Correct. And the new guidelines also lowered the threshold for resistance. It used to be 3 Wood units, and now it's down to 2 Wood units.
Okay, so that changes the entire categorization of the disease. The review talks about two different phases of this, IPCPH and CPCPH.
Yes, the two distinct stages. So IPCPH is isolated postcapillary pH. The pressure is high above 20, but the resistance is still at or below 2 Wood units.
So the pipes are under pressure, but they haven't thickened yet.
Exactly. It's a purely mechanical backup of fluid from the failing left heart. The structural integrity of the lung vessels is still mostly fine.
And the other side of that coin.
That's CPCPH, combined post and precapillary pH. That's when the resistance crosses that 2 Wood unit threshold. Now you have severe vascular disease. The vessels have physically remodeled. They're thick, stiff, and scarred.
What's fascinating here is that the review notes just moving that goalpost to 2.2 Wood units in one study identified 55% more at-risk individuals.
It's life or death to catch them early, because once you cross into CPCPH, your mortality risk is 2.5 times higher than the isolated stage.
That's terrifying. So if the problem starts in the left heart, how does it physically end up destroying the lungs and then the right heart? Like, what's the actual domino effect here?
It's a very specific step-by-step biological cascade. Step 1 is the passive transmission of elevated left atrial pressure, or LAP.
The drain gets clogged.
Right. In HFrEF, the left ventricle is weak and dilated, so blood pools. In HFpEF, the left atrium is incredibly stiff. Either way, the pressure inside the left side of the heart spikes. And because there are no valves in the pulmonary veins to stop backward flow,
It just shoots straight back into the lungs.
exactly, right into the microscopic capillary beds, which triggers step 2, endothelial dysfunction and vasoconstriction.
Because the blood vessels in the lungs basically panic under all that pressure.
They absolutely do. The delicate inner lining, the endothelium, starts to crash chemically. Where normally it produces nitric oxide to keep the vessels relaxed and open.
But under stress, that drops.
Nitric oxide plummets, and the cells start pumping out endothelin-1, which is a massive vasoconstrictor.
The ROCK pathway, right?
Yes, endothelin-1 activates the ROCK pathway, which basically inhibits the enzymes that let muscle relax. So the smooth muscles around the lung vessels just violently clamp down.
It's like the lungs are trying to protect themselves from the high pressure, but by clamping down, they just make the traffic jam infinitely worse.
The ultimate tragic irony of our biology. And that constant constriction leads to step 3, pulmonary vascular remodeling and inflammation.
The pipes literally change shape.
Yeah, the endothelium releases growth factors like VEGF and TGF-beta. These tell the smooth muscle cells to multiply rapidly, and fibroblasts start dumping collagen into the vessel walls.
So these flexible tubes turn into stiff, rigid pipes.
Exactly, which brings us to the final fatal phase. Step 4, right ventricular remodeling and ventricular arterial uncoupling.
So picture the right ventricle, the RV, like a water pump. It's normally a low-pressure pump, just gently moving blood through spongy lungs. It's thin-walled. But suddenly, it's trying to push fluid through a calcified, narrowed pipe.
The physics just overwhelm it. The RV tries to adapt by bulking up compensatory hypertrophy, but eventually it hits a wall.
It uncouples.
RVPA uncoupling. The right ventricle just exhausts its ability to match the resistance. It stretches out, dilates, and turns from a healthy crescent into a ballooned-out sphere.
And the valves get pulled apart.
Severe tricuspid regurgitation. Blood washes backward into the right atrium and then into the rest of the body. You get systemic venous congestion, the liver swells, the kidneys start failing. It's the ultimate death knell for prognosis.
That is just brutal. A subtle stiffening in the left heart eventually destroys the liver and kidneys by way of a microscopic war in the lungs.
It really is.
But practically speaking, the symptoms of this, shortness of breath, swelling, they look exactly like general heart failure. How do doctors even spot this specific progression?
It is an incredibly difficult diagnostic maze. Because the symptoms overlap so much, you have to use a stepwise approach.
Starting with the basics, I assume.
Right. Non-invasive clues first. You look for an older patient, dyspnea on exertion, orthopnea, which is shortness of breath when lying flat. A history of AFib, severe obesity.
And biomarkers like BNP.
Yes, B-type natriuretic peptide. Plus, we use pretest probability scores like the H2FPEF or HFAPEF algorithms to stratify the risk before doing anything invasive.
Because the invasive part is the gold standard, right?
Right.
Heart catheterization, or RHC.
It is the cornerstone. You take a Swan-Ganz catheter, which has a tiny balloon at the tip, and thread it through a vein in the neck or groin, all the way into the right ventricle and out into the pulmonary artery,
And they wedge it deep into the lung.
in West Zone 3 specifically.
Yeah.
Then they inflate the balloon to block the forward flow from the right side.
So they can read the static back pressure from the left side, the
Yeah.
pulmonary artery wedge pressure, the papillopy. But here's where it gets really interesting for me. Measuring this isn't exactly plug and play, is it? I mean, the margin for error sounds huge.
Yeah. It is notoriously prone to error. First, the external pressure transducer has to be perfectly leveled at the patient's mid-chest. An inch too high or low, and gravity ruins the reading.
And what if the balloon doesn't seal perfectly?
Falsely elevated readings. But the biggest issue is usually the patient's fluid status.
Because of diuretics.
Exactly. Heart failure patients are often heavily diuresed, or they've been fasting before the procedure. So they're artificially dehydrated, you measure them at rest, and the pressures look totally normal. The doctor might say, great news, no pulmonary hypertension, and be completely wrong.
It's like testing a car's transmission while it's parked in the driveway. You have to actually drive it to see the failure.
Which is exactly why provocative testing is becoming standard.
Right.
We do a fluid challenge, infuse 500 milliliters of saline rapidly over 5 minutes.
Just to flood the system and see if the left heart panics.
Right. A stiff left heart can't handle it, and the PAP spikes above 18 millimeters of mercury.
The review also mentioned exercise testing during the catheterization, which sounds wild.
Pedaling a stationary bike on the cath table. In one study, doing that reclassified the prevalence of the disease from 20% at rest up to 39% during exercise. It unmasked the disease in half the patients.
That's a massive shift. Oh, and the non-invasive imaging they're working on? The 129X MRI? That blew my mind.
The hyperpolarized xenon gas MRI. It's pure science fiction. The patient inhales the gas, and the MRI tracks exactly how fast the xenon atoms transfer from the air sacs into the red blood cells.
So they can physically see the capillary thickening without ever inserting a catheter.
Exactly. It quantifies the micro-level changes perfectly.
Okay, so let's say we diagnose it perfectly. Now we hit the biggest listener question. If this is pulmonary hypertension, why can't we just give them the drugs we already have for pulmonary hypertension?
A completely rational question, but historically a catastrophic strategy. The drugs we have are for Group 1 pulmonary arterial hypertension.
So isolated lung disease.
Right. Those drugs like endothelin receptor antagonists or prostacyclins are pure pulmonary vasodilators. They force the lung vessels wide open.
But if the left heart is stiff?
You flood the lungs. The left heart is the drain. If the drain is clogged and you suddenly open the faucet by dilating the lung vessels, a massive volume of blood rushes forward and has nowhere to go.
Fatal pulmonary edema. You're literally drowning the patient from the inside out.
Yes, and the trials prove this. The MELODY-1 trial tested macitentan in these Group 2 patients, and it caused severe fluid retention and worsened their heart failure.
And the prostacyclins were even worse.
The epoprostenol trial showed that while the lung resistance numbers looked better on the monitor, the patient's mortality paradoxically increased. The influx of blood overwhelmed the left ventricle, and they died faster.
So if we connect this to the bigger picture, you simply cannot treat the lungs without respecting the mechanical capacity of the left heart.
That is the cardinal rule.
So since the old playbook basically failed, what is science doing to actually fix this? What's on the pharmacologic horizon?
Well, we're starting by repurposing some incredible systemic heart failure drugs, like the SGLT2 inhibitors.
Like dapagliflozin.
Right. They were diabetes drugs originally, but they drastically reduce the PADIP over time and improve RVPA coupling. Also, ARAs, like sacubitril valsartan, are showing emerging evidence in lowering MPAP.
And the metabolic angle is huge now.
Yeah, treating the underlying adiposity and obesity with things like metformin or GLP-1 agonists. We know that systemic inflammation from visceral fat drives a lot of HFpEF.
Okay, those are the repurposed ones, but I want to talk about the truly novel, targeted stuff. Let's look at sotatercept.
Sotatercept is a fascinating biologic. It was just approved for Group 1, and now they're testing it for Group 2 in the Cadence trial.
That's TGF-beta trap, right?
Exactly. We talked about how TGF-beta is the signal that tells the blood vessels to scar and remodel. Sotatercept is a fusion protein that literally acts like a sponge in the bloodstream, binding up those TGF-beta molecules before they can reach the vessels.
So it intercepts the command to build scar tissue. That's amazing. What about the relaxin analogs?
Volin-relaxin and TX45. This is brilliant biomimicry. The human body makes the hormone relaxin during pregnancy to safely dilate blood vessels so the mother can handle the extra blood volume.
So they basically bottled the superpowers of pregnancy.
Right. These drugs mimic relaxin to cause gentle vasodilation and antifibrotic effects, softening the tissues without causing those deadly sudden fluid shifts.
Then there's levosimendan. This one acts as an inotrope, right?
It's a calcium sensitizer. It makes the right ventricle's muscle fibers more sensitive to calcium, so the RV can squeeze harder and more efficiently.
But wouldn't squeezing harder just push more blood into the clogged lungs?
It would if it didn't also act as a venodilator. It simultaneously dilates the large systemic veins in the body, which reduces the preload, the amount of blood returning to the heart. So it helps the pump squeeze while giving it less fluid to push.
Wow, covering both ends of the equation. And the review mentions JKO7 and Fasudil.
JKO7 is a neuregulin EGF fusion protein aimed at actual cardiac regeneration. Historically, activating those pathways caused tumors, but JKO7 is engineered to rebuild heart muscle safely without the cancer risk.
And Fasudil targets that exact ROCK pathway we mentioned earlier, shutting down the vasoconstriction at the cellular source.
Precisely.
But drugs take months to remodel tissue. If a patient is actively failing, they don't have months. So let's transition to the cyborg solutions, the invasive device therapies currently in trials, because these sound incredible. Start with pulmonary artery denervation, or PADN.
So the pulmonary artery is wrapped in overactive sympathetic nerves that are constantly dumping adrenaline, telling the artery to clamp down.
The alarm system is broken.
Right. PADN uses a catheter to deliver radiofrequency or ultrasound energy directly into the artery wall, literally zapping and ablating those nerves.
Yeah.
It physically cuts the alarm wire, forcing the artery to relax.
They're testing this right now, right?
The POLICY LHD trial. 500 subjects with severe CPCPH. We're waiting on the long-term data.
Next is the Area CV system. I visualize this as a literal shock absorber for the right heart.
It's a mechanical proxy for healthy lungs.
Yeah.
They implant a gas-filled balloon into the main pulmonary artery.
So during systole, when the heart beats,
The blood pressure squishes the balloon inward. It absorbs the pressure spike, drastically reducing the afterload on the right ventricle.
it takes the beating instead of the heart.
Exactly. And then during diastole, when the heart relaxes, the gas expands the balloon back out, physically pushing the blood forward into the lungs. It artificially restores pulmonary artery compliance.
That is mind-blowing. Finally, the transcatheter atrial shunts, devices like Corvia, Alleviant, and Atcher.
These target the root cause, the high left atrial pressure. They puncture a controlled hole, a shunt, between the left and right atria or the coronary sinus.
Like a pop-off valve on a pressure cooker. When the pressure spikes, the blood vents over to the right side to decompress the left atrium.
Exactly.
Wait, doesn't that just violently push the problem over to the right side of the heart? Which is already failing.
You've hit on the exact nuance that makes this so tricky. The premise is based on the Starling curve. A relatively healthy right heart handles extra volume much better than a stiff left heart handles extra pressure.
So it's a trade-off.
Yes, but the right ventricle has to be healthy enough to take the trade. The REDUCE-APHF2 trial showed really mixed results. In patients with advanced pulmonary vascular disease whose right ventricles were already uncoupled, adding that shunted blood was disastrous. It actively caused harm.
But for early-stage patients, it worked.
Beautifully, it decompressed the left side, and they could exercise again. It all comes down to unbelievably precise patient selection.
Which perfectly transitions to the final issue here, fixing the science. Because the review makes it clear that the way we run trials for this disease is fundamentally broken.
It is a systemic failure. The endpoint problem is massive. For decades, the FDA standard to prove a pulmonary drug works has been the 6-minute walk distance.
Literally just seeing how far they can walk in 6 minutes, which makes zero sense for these patients.
Exactly. A young patient with isolated group 1 disease, sure. But group 2 patients with heart failure are older, usually obese, with arthritis, diabetic neuropathy, AFib.
So if they stop walking, you have no idea if their lung pressure was too high or if their knees just gave out.
You can't separate the data. And worse, there's no agreed-upon minimal clinically important difference, or MCID. We don't even have a mathematical agreement on what constitutes getting better for these patients. Is a 3-millimeter drop in pressure a cure or a rounding error?
So what's the solution?
Deep phenotyping. The Pulmonary Vascular Disease Omics program is a great example, combining genomics, metabolomics, and imaging to treat the individual's specific molecular breakdown, not just broad symptoms.
And changing what we measure anatomically, right? Focusing on left atrial compliance.
Yes, the left atrium isn't just a passive conduit. Atrial myopathy, the physical stiffening of the left atrium itself, is a massive driver of the disease that is routinely ignored in trials. We have to start measuring the stiffness of the chamber, not just the pressure inside it.
And finally, there's a huge issue with global equity in these trials.
This is critical. The multi-million-dollar trials for these biologics and cyborg devices are almost exclusively run in Western high-income nations.
Which completely skews the data, because in low and middle-income countries, a massive amount of this disease is caused by rheumatic heart disease.
Exactly. An untreated childhood strep infection causes the immune system to attack the heart valves. It destroys the left heart and causes lethal pulmonary hypertension in early adulthood.
And those millions of patients are just virtually ignored in the clinical trials.
Systemically excluded. If we're spending billions developing therapies for Western metabolic heart failure, but ignoring the infectious causes prevalent globally, we are failing the core mandate of global medicine.
It's an incredible call to action for global representation, and it leads to this final, really provocative thought to ponder.
Yeah, we've spent decades treating the heart and the lungs as two completely separate machines.
Governed by two separate specialties.
Exactly. But what if the ultimate cure for pulmonary hypertension doesn't lie in the physical structure of the heart or the lungs at all? What if it lies in the microvascular metabolic signaling that connects them, the invisible wiring of the body?
Like the GLP-1s crossing over from obesity to heart failure.
Exactly. As we look at those systemic crossovers, perhaps the real breakthrough will come from entirely outside traditional cardiology.
To you, the listener, we hope this exploration provided the clarity and the context to understand exactly where the future of cardiovascular medicine is heading. Thank you for watching The Funnel Effect.